we're going to talk about the erythrocytosis versus polycythemia. What's the difference?
Hello, the Balanced Hormones.
To another question time with Dr. George Touliatos. Dr. George is the author of this book and a couple of others, Bodybuilding, the Good, Bad and the Ugly. Pretty much a comprehensive book on the use of PEDs in bodybuilding and, you know, as it says, the different aspects of it. So today we're talking about hematocrit, hemoglobin, you know, a common topic on TRT and in the community. And sort of discuss different things around it. So obviously this is Mike, I'm Sam. So George, welcome. Thanks for coming on.
Happy New Year.
Thanks, mate, you too.
Good to be back to the show, guys.
What is hematocrit and what is hemoglobin? Just for the basics to begin with.
So hematocrit is the percentage of red blood cells in the whole blood, in the plasma. And it's about the percentage of the red blood cells or the erythrocytes. Now, hematocrit is affected by factors like hydration. So when we have overhydration, we have a more diluted blood in the plasma, but this is pseudo. So it means that when hydration levels get back to normal, then hematocrit may change a little bit, 2 or 3%. Reversely, when we are dehydrated, and we evaluate this by elevated urea in the biochemical labs, then the plasma becomes more concentrated, and so hematocrit becomes pseudo-elevated. However, the hemoglobin is a more accurate factor index, which is a protein, of course, consists of iron molecules, and it's actually the 1/3 of the hematocrit. So, for instance, when we have a hemoglobin of 15%, then most likely the hematocrit to be under normal conditions 45%. Now, if we become dehydrated, it may go up to 47%, or if we become overhydrated, which is a trick to lower hematocrit before the blood work, it may go to 43, for instance, you know. But this we can verify by the measurement of urea, serum urea, that is also elevated by protein and nitrogen, but also it's according to the plasma, if it's diluted or concentrated.
Okay, so that's the basic about that. Is it true that it's like a percentage? So once they centrifuge your sample of blood,
yes. So when we get a blood sample, then we centrifuge this in order to separate the plasma, which is the yellowish. You have the reddish, the erythrocytes. Now in the plasma, you contain everything in the biochemical and hormonal labs. So electrolytes, vitamins, hormones, biochemical tests. So this is the plethora of the lab work that we estimate. On the top, on the erythrocytes, we have the red blood cells, you know, and we separate them after centrifugation. Actually, they separate, and now the more hematocrit somebody has, the lower percentage of plasma will give. So we have a sample that we have the red blood cells and we have the yellowish plasma. Now, the higher the hematocrit, the higher the percentage of the red blood cells and the smaller plasma. So somebody like me with a high hematocrit need a higher sample in order to make evaluation of the biochemical and the rest hormonal labs. An anemic person will have a very small percentage of red blood cells and a very longer plasma that is intimidated. So even by a small amount of blood, you can centrifuge this in from an anemic person, and you can estimate a wide variety of labs.
So that's why if someone's more hydrated, it can affect the hematocrit.
Also, yes.
Add more water to the blood, essentially.
By 2 or 3%, yes.
Okay, that's cool.
Also, this is a good reason to hydrate before the blood, because the blood transfusion, you know, or the blood suction, because a dehydrated person makes the blood more thick, you know. So you kind of dilute the blood if you become well hydrated, And so the dropping of blood would be way easier.
Okay, cool. So next question would be, why is it monitored on TRT?
Yes, all the androgens, so either anabolic steroids or the testosterone, which is the main androgens, are capable of stimulating erythropoietin from kidneys and afterwards red bone marrow for erythrocytes production. Actually, this is what androgens do in first place, and they treat anemia. However, abusing androgens or steroids, anabolic steroids, will lead to secondary erythrocytosis. Okay, because we have the primary erythrocytosis, which is the polycythemia, and it's a medical case where the JAK2 hereditary test becomes positive, and you have more red blood cells production in first place. However, the androgen induced is by the stimulus of testosterone, for instance, or other steroids, anabolic steroids.
Okay, so if you're on TRT, or if you're like an athlete or something who's, you know, abusing
EPO.
steroids or EPO, I suppose, is the
EPO in first place, you know, it's the main stimulus.
Then that's why, because there's a potential for it to increase, because that's what it medically was used for, some of the steroids as well.
Absolutely, yes. Right? To treat oxymetholone, for instance, for aplastic anemia.
Okay.
So then it's a good thing that testosterone can raise hematocrit and hemoglobin in those who are anemic. But lots of confusion is out there between the words polycythemia and erythrocytosis. What do you think the main differences are?
Yeah, well, polycythemia vera, and this is where you have to perform this JAK2 hereditary test. Polycythemia vera involves the elevation of both erythrocytes and thrombocytes, the platelets. And polycythemia vera is treated by the use of hydroxyurea drug. Now, erythrocytosis, if you take the etymology of the word, speaks about erythrocytes, red blood cells. Okay, so it's about elevation just of red blood cells, not platelets, not thrombocytes. So this is the main difference. And if we differentiate between erythrocytosis and polycythemia, we look about the platelets. And if they are below 200,000, then it's more likely and safer not to have thrombotic effects. Okay. Now there is a compensatory mechanism in the bone marrow. Now, if somebody produces red blood cells for any reason, there is we observe a lowering in the thrombocytes. So they go one against the other. Now, people with lower hematocrit that comes to my at work, I've seen, for instance, 45 hematocrit, they have more elevated platelets. So it goes one against the other. And sometimes I guess this is a homeostatic mechanism for safety reasons from the organism, you know.
Okay, so that's in erythrocytosis. So for a quick summary, polycythemia vera is when you're looking at red blood cells, white blood cells, platelets,
thrombocytes, and erythrocytes. So platelet,
everything's going up. Yeah. Okay. Yeah.
What about iron levels and ferritin? How does that come into play with polycythemia vera?
Having more red blood cells brings higher demands of iron. Also, more red blood cells, you know, they use more. They have greater demands for iron. That's why some people with higher red blood cells, over 6,000, for instance, 6 million, including me, we have lower iron levels because of the high demands of more erythrocytosis. But if myself have low ferritin and iron, it's most likely because of the frequent donations that I have to perform every 2 months, for instance.
The TRT patient, though, I mean, unless they have their diagnosis already of polycythemia vera, that's not something they have to worry about. It's the erythrocytosis part that you're talking about.
Yes, erythrocytosis induced by the use of the main androgen, testosterone.
Okay. So I suppose the main sort of topic of debate, isn't it, is it dangerous to have erythrocytosis, you know, on TRT? And should you donate and things like that? So I know that you've described there's lots of different viewpoints and theories about this, but I mean, did you want to talk about, you know, I suppose the potential reasoning for why you might want to donate blood? You know?
Well, the blood becomes more thick, the viscosity elevates. Especially other factors that contribute on that are the platelets number, the fibrinogen, which is also a clotting factor from the liver, blood pressure also, hydration levels. If you are more dehydrated, then the blood is even more thick, even in a pseudo way, because as I told you in the beginning, hemoglobin is the most accurate. So you may have 19 hemoglobin and hematocrit will be 55, for instance, instead of 58. But what hematologists are concerned of, and pathologists, is the possibility and the potential case of becoming more viscous the blood and to perform some ischemic stroke or deep venous thrombosis. Now, even those cases, they have to be accompanied by also hypertension or atherosclerosis, and also people who are following a sedentary life and they don't have regular physical activity or exercise, cardiovascular or resistance training, because through exercise, the blood is more likely to circulate, and avoid the thrombosis. And when there's no movement, there's no contraction of the muscles, and the venous blood does not go upwards to the heart. So motion and motility of the muscles, yes, is a major factor to avoid the venous thrombosis. There are some other agents that we use, like, for instance, fish oil, EPA, and DHA, that makes more flexible the cell membranes of the red blood cells. They can pass through the capillary network, and pentoxifylline also, but also aspirin, which is salicylic acid, and it can inhibit prostaglandins and platelet aggregation as a result.
Okay. The potential theory behind potentially needing to donate is that then if you have other factors like high fibrinogen or other clotting factors, history of atherosclerosis,
platelets,
high risk of
elevated
platelets, or plaque,
high blood pressure,
and maybe plaque. If you're fully
diabetes and vasculopathy.
Okay, so if you were fully atherosclerosed, if you had peripheral artery disease or something like that, where you've got calcified arteries, one might make the argument that even if you had higher red blood cells and even low platelets and things like that, you may want to take the precaution of keeping your blood less thick. So that might be a reason to consider it. Is that sort of right? Is that?
Yeah, think about this scenario. We have a bodybuilder who has anabolic steroid-induced erythrocytosis. Now he has a hematocrit of 55 plus, and he performs a heavy squats under the use of pre-workout stimulants. So now we have erythrocytosis plus high blood pressure coming as a result of the stimulants and also the heavy squats. So in this case, you may get a stroke, not just ischemic, but also hemorrhagic, because you may rupture the blood vessel, and you have a higher amount of erythrocytosis. So it's the combination, it's like becoming, an atomic bomb altogether, synergistic effect.
Okay, so in like an unhealthy individual or a unique situation, it could add an increased risk potential.
More contributor factors, yes. So you have to lower the risk by eliminating risk factors.
Okay.
Have healthy vessels, blood vessels, no blood pressure, no diabetes, no atherosclerosis, low platelets, well hydrated, and the use of pentoxifylline or fish oil and aspirin in order to have a thinner blood.
Okay, cool.
What about some other treatments possibly for this? We've heard Losartan for blood pressure lowering.
It has shown some lowering on the erythrocytosis, and erythropoietic effect. So lowering managing of the hematocrit and the hemoglobin. I personally take 25 milligrams, so I split one Losartan a day, and I'm taking my CBC on next Monday. I want to see in 10 days what my results are, plus a phlebotomy that I performed before the New Year's Eve,
CBC in the UK is referred to as, I believe, FBC, full blood count.
Yes.
So the another one, because I was telling you about this, was I know they talk about grapeseed extract, and grapefruit and things like that, and I took a new pre-workout, like a non-stimulator on like a pump workout, and it had grapeseed extract in it, and I've taken it for about a month now, And that's the only thing I've changed in my protocol and things like that. And my hematocrit, it may not be this, but maybe it's just coincidence, but my hematocrit's gone from 0.52 to 0.45, I think it is, and my hemoglobin's come down as well from
another thing we have to worry about
to 166. Yeah,
well, I think it's the arginine, which is a compound in the grape seed that has this effect. But another factor we shouldn't neglect is the obstructive sleep apnea and sleep apnea or snoring. That is a hypoxic factor for EPO stimulus.
Okay.
So you told me yourself that you use this kind of CPAP mask or this.
Yeah, so I've got sleep apnea and it's treated, and I've got a good seal and things. But
and you managed to control your hematocrit, eh?
Yeah, so it was higher before I started my CPAP, and obviously, I mean, the simple description of it is, I suppose, I was having low oxygen in my sleep, so my body with enough testosterone and effectively through, I suppose, the EPO pathway was going, well, Sam is hypoxic in his sleep. He needs some more red blood cells to carry more oxygen, almost like altitude training sort of thing.
Yes.
In a way, in my sleep. It definitely came down after I got treated for that. Do you think you might have sleep apnea as well, potentially?
Yes, I believe so. And I try to sleep on the side, but eventually I will not avoid getting the CPAP mask.
It's not bad, George. You can join the club.
Continuous airway pressure just to splint your airway open and stop it collapsing if you've got like thick neck muscles or structural difference.
But it's not oxygen supply, yeah?
It's forced air. It's like creating a stent within your throat, so it collapses, and whilst you're sleeping, the muscles relax, and this opens up that airway so that you are getting proper oxygen at night. But it's oxygen from the ambient air.
That's all it is. It's just it ramps up at night. If you begin your airway to collapse, because there's continuous positive airway pressure going through, it's splintered open for you. Yeah, well, you have to generally use it permanently. But if you have like excessive weight and you lose weight, apparently that sometimes can help. And I'm just parroting what my doctor said at the sleep clinic. I think there is something called central sleep apnea, which is rarer, where you don't get the signal from the brain. But some guys use like a gum shield where it holds the jaw forwards and stops the jaw.
Is this the same effect of? Is this as effective as CPAP?
I don't think so. I think it works for some people that have mild sleep apnea. So I think if you're in the UK, obviously you can go privately and find someone, but generally you have to go to your GP. They'll give you a questionnaire. They're the gatekeeper to sort of the sleep studies, and you have to say, I'm falling asleep during whatever your symptoms are.
So the same happens to people who live in high altitude, over 2,000 meters. However, those people are adapted, and they don't have incidents of stroke and deep venous thrombosis or cardiovascular. This is an adaptive mechanism, a natural, progressively.
So could that same adaptation mechanism work in men that are on TRT?
Perhaps, because after 6 months, usually the hematocrit stabilizes. We have to observe, to watch out that 20-year-old bodybuilders abuse gear 2-3 grams per week, and they rarely perform a phlebotomy, unlike 40-year-old guys who use just 200 milligrams, 1/10 of the 2 grams that the others use. And they have to give, for instance, every 3 months, blood supply, blood phlebotomy or donation. And his thoughts has to do about endothelial dysfunction and atherosclerosis. And if you are managed to restore your calcium score or your plaque or your endothelial dysfunction, that I no longer elevate my hematocrit with the same dose of replacement therapy.
Okay,
it's about chelation therapy.
So the endothelium and nitric oxide production helps with vasodilation and things like that.
Yes.
Are you saying that if we get older and we lack that and there's dysfunction?
Aging, the blood vessels get older, and the older they get, the endothelium becomes disrupted.
Okay, so that's a potential.
Mind that aromatase inhibitors produce endothelial dysfunction, and anabolic steroids, of course.
Interesting.
Also, and smoking. Smoking produces endothelial dysfunction of clotting because when endothelium is disrupted, then it attracts more platelets. It's like an ulcer that the platelets have to go there and make a clot.
I suppose what are then the arguments for not donating? If you're on TRT, I know Mike's been living with slightly elevated hematocrit and hemoglobin for 20 years.
There was a period where I was giving blood for nearly, it seemed like every 3 weeks for a while, and this was just getting out of hand. It just wasn't sustainable to do it. And like we talked about earlier, the more I was giving, the more there was a chance that the body would rebound and
yes, exactly.
more.
Yes.
So, after a while, I just said, well, the doctor prescribed pentoxifylline for something else, but it does seem to help make the blood more malleable, and it wasn't really an issue. And so it stayed stable, around 17.5 to 18 for hemoglobin, and my hematocrits anywhere from 50 to 52.
Well, think about it the other way. You never become anemic, and you have high oxygen capacity.
That's true. So I'm not too bothered by it, and I don't get the side effects, though we do know some people do get very red and flushed in the face. They get the itching when they come out of the shower. So that I think it depends on the individual.
Yeah. So why would you? I suppose it depends doctor to doctor, person to person, what sort of I suppose the theory and evidence that you look at. Because what I see is like you've got Mo Farah that trains at altitude all year. He's probably got a high hemoglobin and hematocrit, and it is adaptation, I suppose, over time. He's not donating blood. You've got cyclists that I suppose they're blood doping. They used to blood dope and chuck a load of extra blood in themselves, through a
marathon runners also.
What's that? Sorry.
Marathon runners.
Yeah, and I suppose people with COPD, I think, can get higher levels as well as an adaptation. I may be wrong with that, but so I suppose that's what people ask, isn't it? Is that do I need to donate? And I suppose what do you think? Do you think it's?
I don't find a reason below 18 hemoglobin and 54% of hematocrit. I tell them just to use a baby film coated aspirin of 100 milligrams with breakfast as a precautionary mechanism. But because I see for myself, if you men, they have the upper range of 18, and women of 16, and also this reflects to 48%, 54%, or the 1/3. So if you're between 17 and 18, I would tell you to use fish oil and maybe a baby aspirin, just this. Personally, I avoid eating red meat in order to take off the 3 main substrates for hemoglobin synthesis: iron, cobalamin, and folate. However, when I donate frequently, I feel so fatigued that I eat red meat for 1 week.
Well, we've been eating red meat nearly twice a day.
Yeah, some controversy on that topic.
Yeah, sorry.
As well. But I suppose if you've got high hematocrit and hemoglobin, and you are concerned about it, I suppose things that you can try or
also
get
smoking. Yeah, I'm sorry, we forgot about smoking.
Yeah.
Because classic carbon monoxide introduction to the system, then EPO, of course, synthesis, and also people who are living in those tents, the cyclists, which is hypoxic tents, and you wake up the next day and this hypoxia stimulates the athlete, the endurance athletes. Yes.
What about people who live in high pollution areas in major cities?
Perhaps this also, they have a respiratory obstructive disease.
Okay. All right.
But it could be also, yes, very good point. You may have a lower oxygen saturation in your blood.
So what should TRT patients then watch out for? Would you say just give blood because it helps the blood supply?
Well, we have to clarify between phlebotomy and blood donation.
Blood donating and therapeutic phlebotomy?
Yes, exactly. So when you are considered as healthy, your hemoglobin should be below 18 or 54% of your hematocrit. Now, when it's above, so 18.5, for instance, or 55%, 56%, you're considered to be ill. So you are phlebotomized because your blood has to be wasted and not be transfused to somebody else because of the higher viscosity. This is the difference. Now, I'm rhesus, negative rhesus, so I'm a global donor. I can give blood to anybody, but I can take blood only for myself. And it's such a shame to waste my blood because it's so precious. It's a treasure, you know?
Okay. That's what I noticed when I was giving blood, nearly every month, if not twice, for a very short time, of course. I thought, what a waste, someone
when I visit big hospitals, they look at me in a very suspicious way.
Yeah.
Why your hemoglobin is elevated? Are you a smoker?
Yeah.
Are you living high altitude? Or maybe what they don't know about the replacement therapy, you need to lower your TRT dosage.
Yeah. Yeah.
And the other way also would be to perform daily or very frequent smaller shots in order to avoid one large dose that may eventually spike on DHT. And there are some assumptions that erythrocytosis is DHT induced.
That's not definite, is it? Because you get plenty of people that have weekly dosages, things like that, and don't experience high hematocrit hemoglobin. So is it a potential thing?
What about the free testosterone that we mentioned before?
So the free testosterone, there was a study that showed that as a predictor for elevated hematocrit and hemoglobin was your free testosterone on trough. And the higher it was on trough, then the more likely you were to get this erythrocytosis. So
I guess proviron elevates hematocrit, DHA also, because they are also androgens, but they also affect the free testosterone.
Do you think it's dose dependent?
Yes. And also testosterone, if you use 50 milligrams per week, I think you're going to minimize your erythrocytosis.
You probably also minimize your sex drive, or
everything. Yes, your fat burning, everything.
And all the other benefits of testosterone. So
you see, you cannot have it all. You can have sex drive, but you may have also elevated blood, and also more testosterone, more aromatization, more acne. You cannot have it all.
So that's
blessed.
So I think if you sorry, mate, I was just going to say in the UK and I don't know in Europe, I think some of the doctors, if you push, even if they look at the theory and they're a little bit like, actually, I'm not quite set on the fact that you must donate if it is higher. I think they will probably err on the side of old guidelines that have been put in place, and they probably will say, you should donate because that's protecting their license as well. So I think that's something you might expect when you come across that with doctors, would you say?
Yeah, but we've also seen some people go to their GP or even a hematologist that said they're not worried until you get well above 56.
Yeah, that's true.
So,
well, again, 56 is obsessive because if you're dehydrated, you may have 18 hemoglobin, instead of 54, you have 56. So watch out in first place the hemoglobin.
Okay. And then also in the UK, there are people with thalassemia, and
when you have thalassemia, the stigma of thalassemia, then your MCV is below 70, and you barely reach 45 hematocrit, even on steroids. These people will never become erythrocytotic. They struggle with anemia, and so they don't fear of this.
So I think that, we see lots of guys before TRT that are anemic with low testosterone. They feel tired, all those sorts of things. So do you think there must be a link between improving that red blood cell count, oxygen carrying capacity, and therefore energy and mood? And
yes. Personally, my hematocrit was 45% at the 6 months barrier when I was waiting for my HPTA to recover after I quitted from bodybuilding shows. So quitting 6 months from steroids, I had 15 hemoglobin and 45 hematocrit. Now, as soon as I started using testosterone, it climbed up progressively,
How do you feel?
With what? You mean?
With low levels, with low hematocrit, do you feel any different? You feel more tired?
I'm kind of tired because, as my dad used to say, he was a pediatrician, you become accustomed to high hematocrit, and now for George, 50% will feel exhausted and tired. Other people are 45, they get used to it, and 50%, they start sweating, and itching. But personally, my lowest for the past decade was, no, for the last 5 years was 45%. I remember when I was on steroids, my lowest was 49 after I had some surgical procedure for an intramuscular abscess. So I never think of myself below 50 while on steroids.
Well, I've seen it, when someone post-surgery is really anemic and then they get given, a pint of blood. Transfusion, EPO, yes. They feel amazing,
Well, my grandmother, we inject her 100 milligrams of DECA. She's 105. We inject her every week 2 DECA of 50 milligrams. We also gave her blood transfusion and EPO. And before she had pneumonia, she had 42 hematocrit. After she dropped to 32, and now she got back to 39. So you see that there's a reaction, but still some people resist.
Yeah. I think you did a podcast with Carl Lenore,
yes.
on the Superhuman Network, about how you use DECA and things with your grandmother post.
Of supplementation, yes.
Really interesting. I mean, you wouldn't hear of that in the UK.
No, probably not.
Well, for HIV patients, I think it's obligatory.
Exactly.
Yeah, exactly. So I suppose the summary is if you have high levels, then things that you can do to lower hematocrit and hemoglobin are stop smoking if you smoke. Potentially try grape seed extracts. I know that some people have tried that. Then you've got things like Losartan, like the ARB.
Aspirin, fish oil, and doxycycline.
But those things don't lower it, do they?
No, they don't lower. They are precautions. They
help to lubricate.
They get effect of they control the platelets, the aggregation. Yeah. They do not minimize, of course, the number of platelets.
Yeah.
CPAP mask for lowering obstructive scenario, which is a major stimulus for EPO.
So sleep study, basically, you've got high levels. Yeah.
Watch out. A vegan diet, when you don't get the amino acids for hemoglobin synthesis, which is a protein. And also a vegan diet will not have iron, hemic iron, B12 and folate. And I guess a vegan diet will lead you to anemia.
So if you want to try and avoid that, you just become severely malnourished in certain vitamins, sort of things, basically. That's what you're saying, the folate and things, right? Okay.
Yeah. Work around to drive down that number.
I suppose more cardio.
More cardio, yes. You know why? Good point. Because when you jog, especially, one step gives some crash to impact on the kidneys. Now, the glomerulus of the kidneys, if you have, for instance, every 1 kilometer you jog, you have 1,000 of steps, and each step is the body weight of ourselves. So the glomerulus in the kidneys become so, like an earthquake, and you start losing blood out of this. That's why marathon runners experience hematuria, but also is a result of excessive rhabdomyolysis. So overdoing cardio make you a little bit lose some blood in the urine or through muscles that break down, they rupture. And this is also an alternative way to keep down your erythrocytosis.
But surely it's also just becoming more adapted to cardiovascular exercise, your oxygen carrying capacity and delivery.
I'm not sure about this, but
it
was shown in marathon runners and not to cyclists so much, because marathon runners, they run so thousands of steps instead of the cyclists who just perform it on a bicycle.
So it's the impact.
It's the mechanical stimulus.
Interesting.
And running and not walking, jogging.
So I suppose what you're saying, every case is different, and if there is a concern or a need to bring down the hematocrit and hemoglobin, there may be other steps, no pun intended, or other treatments or supplements that may help. But I think it depends on what you and your doctor decide is the cause or the reason for it, and what you decide as far as the outcome and the treatment.
Avoid also other factors like atherosclerosis, diabetes type 2, high blood pressure, that makes vessels more fragile, more occluded, and high cases of cardiovascular disease. Also, sedentary life, not walking or not having exercise, will make blood to be more viscous and less thin.
All right.
That's great.
So it's multifactorial.
Yeah. So next time we see you, you're going to show us your CPAP mask that you've got from the hospital.
Well, I sleep alone, and then I can live with that because I'm a bachelor and sleep alone. So
you've got no one to look at you. Yeah. Okay, great. So hopefully that was a helpful summary.
Yeah, I think that was good.
Is there anything else you wanted to add, George, about that?
No, guys. That phlebotomy is something needs to be more considered by the hospitals because they look you in a suspicious way when you phlebotomized, unlike when you donate to the Red Cross, which is something you offer. And when you get phlebotomy, when you say I need a phlebotomy, they ask you for various reasons why, and usually they don't. So
that's right. People have said that. If you go in for a blood donation and you say,
"Oh man, they bust your
doctor says I need to donate" or something like that, it's definitely a no, isn't it?
They look you like an alien. They ask you 1,000 questions, why and that, and they finally they deny.
Yeah.
So maybe you ought to donate blood out of the goodness of your heart to help.
Well, my sister used to take 2 large, syringes with 50 ml each for the horses. And she used to draw me blood from each arm, 1550. But still, it's not a lot. It's just 100 ml. Now, consider that the 1 unit of blood unit is 450 ml, and this lowers about every 300 ml. You lower 3% of hematocrit and 1 unit of hemoglobin. So perhaps 450 ml of 1 unit of blood lowers 4.5% of hematocrit and 1.5% of hemoglobin. 1.5 unit, yes.
I suppose another thing, I suppose it happens more in America and things like that. I mean, it's less known and done in the UK, but when people are adding like Deca, nandrolone to TRT for joints and things like that, that's better, isn't it, right? Is that better at increasing red blood cell count?
Yes, but I think it's also dose induced because I add 5 milligrams of Deca every other day. So just 25 milligrams per week. This is something...
sort of a dose situation as well.
It's not even half of the ampoule, But I do it for lubrication reasons, nothing more. Perhaps I'm very slight anti-catabolic, but just, for some anti-aging. But I guess that if I also stop using Proviron 25 a day, DHA to 25 a day, and Deca at 25 per week, and just using testosterone at only 100 milligrams, this is what I use. Maybe, yes, my hematocrit will be lower,
And also a CPAP mask, that's key. You need to get on
and the CPAP mask, yes. I'll try to use it, yes.
No, I'm joking.
I'll give it a try, yes.
Yeah, try the mouthpiece first, maybe,
No, I want to use the real thing, so...
That's cool.
I'm still taking Losartan, we'll see.
Yeah, it'd be interesting to see. We'll feedback on that. All right, well, thanks for coming on, George. I think that's...
Yeah, thanks, George, and thanks, everyone, for watching.
If you want to watch more videos like this, we're going to join George again in a week or so.
Write down your questions so we may answer them.
Yeah, give us some questions, put them in the comments. We're gathering questions anyway from other people, but that'd be great if you've got any questions to ask George. Please like, subscribe, hit the notification bell if you want to see more videos like this and have similar content.
And also leave comments. We will answer the comments that you leave on there. So.
Yep, and we'll try and get back to you. So thank you very much.
Thank you. Cheers, George.
Bye.
Thanks. Bye.